Good morning, guys. So this is the last class in orthopedics. That is a bone tumor. This is a big class, and in the last time we talked about the benign bone tumor or tumor-like conditions. So today, okay, we are talking about giant cell tumor, which is again a type of benign tumor. And after that, I'll enter into the malignant conditions or tumors of the bone. Let's start. Now, what is giant cell tumor? Okay, let's talk about it. Now, giant cell tumor is a distinct neoplasm which arises from non-bone forming supportive connective tissue which are present in the bone marrow. So they are not, formed from bone forming cells or bone cells. Rather than that, they are developed from non-bone forming supporting connective tissue or stromal cells. And if we take the histopathology from this giant cell tumor, we can see giant cells present in them. Giant cells means big looking cell, okay, larger cell. That's why the name is giant cell tumor. These giant cell tumor, they look like osteoclast looking cells, These giant cell, they almost look resemble osteoclast. And what is osteoclast? Yes, what is osteoclast?
Macrophages of the bone resolving cells.
Exactly. Okay. Osteoclasts are bone reserving cells, or rather, they are the type of macrophages. The macrophages which are present in the bone are called osteoclasts. Now, remember one important point here. Okay, please mute yourself. Remember one important point. This giant cell tumor doesn't, form or doesn't develop from osteoclast. They doesn't develop from osteoclast. Rather, they are having those giant cell which resemble osteoclast or they look like osteoclast. That's why the tumor is also known as osteoclastoma. Osteoclastoma. So it may be used as a synonymous term for giant cell tumor, though they are not formed by osteoclast. Only 5% of them are primary bone tumor and 20% of them are benign bone tumor. Sometimes they can become malignant as well and they can get metastasized from one place to other. They almost affects skeletally mature patient in the age group of 15 to 40. So this is the age group for giant cell tumor. So let me underline these important points for you. So later on you can revise them, 15 to 40 with a peak incidence in later half of third decade. Female to male ratio is almost the same, 1.5 to 1, almost the same. But malignant giant cell tumor is more common in the males. So let me repeat again. Giant cell tumor are having giant cell inside them. They resemble osteoclast, but they are not made up of osteoclast. Let's move on. Now see there. What are the sites of involvement? In which parts of the bone are they common? First of all, they are usually solitary lesion or single, but sometimes they may be multicentric or they may be present in the multiple site also. But look at the percentage, it is very rare. And they are usually seen at the distal end of the femur, okay, distal end of the femur, which is a very common site for so many different types of malignancy, proximal end of the tibia, distal end of the radius, upper end of the humerus, and lower end of the tibia. So these are the common site for osteoclastoma or giant cell tumor. They are mainly present in the cancellous bone, okay, which are presented towards the end of the bone. And sometimes they are also present in the hand, spine, and pelvis. Okay, so these are the common site. Now, what are the clinical features of giant cell tumor? What happens to the patient? Now, the patient may be having pain in that particular area, swelling. Okay, of course, this is a tumor, so swelling is also common. There is a restriction in the joint movement, or the range of motion in the joint is restricted because it is very near to the joint. There is muscle wasting in the long, effect as a long effect of the tumor, and the tumor present there for a longer duration. There may be neurological sign because of the damage of the nerves. There may be pathological fracture because that part of the bone is weak now. Okay, and in a malignant type of giant cell tumor, there may be chance of pulmonary metastasis. It is present in almost 3% of the cases. Now, if we take a biopsy from that part which is having giant cell tumor, we can see this type of features. So this is the pathology or histopathology, you can say. This is a gross. Okay, let's talk about the gross feature first, and then we go to the microscopic one. So the end of the bone is expanded because this is a big tumor which expand the end of the bone. Another important point, it is eccentrically located, means in the outer part of the bone the tumor is present rather than at the center. Eccentric means towards the outer part, okay, or towards the margin. And see here, epiphyseal metaphyseal region of the bone. Every student know by now, epiphysis is the end of the bone. Metaphysis is near to the epiphysis. Okay, it is the area between diaphysis and the epiphysis. So that is the site for the development of giant cell tumor. Periosteum has become very thin because of stretching, or it can even destroy it. There may be fleshy, dark brown or soft, friable mass inside. You can see that in the picture right here. This is the gross morphology, and sometimes even cystic species are seen. And that's why when we take the X-ray, it is very commonly confused with bone cyst, either simple bone cyst or aneurysmal bone cyst, or sometimes even chondromyxoid fibroma. So we'll talk about them in the radiological appearance. Now, okay, here we come. How it looks on the plain X-ray. Now, see this. Okay, this is a typical giant cell tumor. So we all know which bone is this, isn't it? So which bone is this? This bone. Yes,
Upper end of the tibia bone, sir.
exactly. This is upper end of the tibia. Okay, every student can identify that bone. Okay, sometimes we can ask that such type of simple question also. See this and look at this bone now. Clear cut. There is an osteolytic area. This is called osteolytic area, and it looks like a soap bubble appearance. See this? There are multiple septation or trabeculae in between the cavities. So this is called soap bubble appearance in case of X-ray. So this is highly suggestive of giant cell tumor in this region. So this is epiphyseal metaphyseal in location. It is expansile lesion and it is eccentrically situated. So all three things you can see here. It is confined to bone and it can break the cortex. Okay, it can break the cortex. If it breaks the cortex and goes towards the soft tissue, then it is a more aggressive tumor. Now, lysis with or without trabeculation gives rise to soap bubble appearance. That's what we are talking right now. Okay, this is soap bubble appearance. Now, sometimes this giant cell tumor may reach very near to the articular cartilage of the joint. In this case, it's a knee joint. And if it does so, then it can cause problem in the joint movement also. Okay. Now, one very important point you need to note here is there is absence of margin of bone sclerosis or punctuate calcification, which is very common in other type of bone tumor like osteosarcoma or even Ewing sarcoma. These are the malignant bone tumor. There is a sclerosis or new bone formation, but in this case, they're absent. I cannot see any white dense area there. So this is important point. Now, you know, let's talk a little bit in detail still because this is an important one. And right after this class, you can, remember what are the important radiological feature. So this is expansile, okay, property of giant cell tumor. Now, in this case, this is fibula bone. Okay, the upper end of the fibula is affected here. So this is a schematic, diagram which is explaining these things. See that the cortex is destroyed, and it may look like a different appearance. This is a soap bubble appearance because of the different trabeculae which are present at the center. So same thing is written again. Sometimes the trabeculation is not seen. See this? I cannot see any soap bubble appearance, but here I can clearly see the soap bubble appearance. So pure lytic type of lesion can also be there. Wait. Okay, I'm back online now. There's a small problem. Okay, now see there. Now we are talking about the giant cell tumor. See there. So these are the X-ray appearance. This is a pure lytic, which is 60% of the time, and the fine trabeculation or soap bubble appearance is present in the 40% of the time. It is really helping us for the radiological diagnosis if this is present. Now, what is the treatment of giant cell tumor? Let's talk at the end. The well-confined, slow-growing lesion with benign histology can safely be treated by curettage and stripping of the cavity. So you can see those cavitation there. So what we can do is we can remove, the content through the curettage and stripping of the cavity. And these are the different instruments which can be used, like burrs and gouges. So we destroy that area, okay, of the tumor. Now, after that, okay, we may swab that area with hydrogen peroxide or by the application of liquid nitrogen, again for the destruction of those cells which constitute the tumor. And then there will be a formation of a big cavity, and that cavity is packed with bone chips. This is known as bone grafting, and then the problem will be solved. If it is a more aggressive tumor or a little bit malignant type, and sometimes even the recurrent, it should be treated by excision followed by bone grafting or even prosthetic replacement. If you have to sacrifice a larger part of the bone, which is near to the joint, you need to do the prosthesis of the joint or that part of the bone as well. Now, sometimes the tumor may develop in the vertebra or the spine. Now, what should we do? Now, it is difficult a type of treatment there, okay, because it may be difficult to eradicate completely. So we need to take help of radiotherapy in this type of cases. Let's move on. Now, let's summarize a little bit about some important points of giant cell tumor. See this, all of these starts with the letter E. This is epiphyseal tumor. Okay, there's no doubt about it. Epiphyseal means this tumor is present towards the end of the bone, especially the longer bones. Okay, but sometimes they are present in the hand and even in the vertebra. They are eccentrically placed. They are expansile type of masses. Okay, they make the bone wide at that area. The treatment is done by extended curettage. We remove all those abnormal content from the bone. And if this curettage fail, we need to go for excision. Okay, this is the surgical treatment. So it is quite easy for us to remember. Now, the malignant counterpart is known as giant cell sarcoma. Okay, giant cell sarcoma. So sarcoma means this is a malignant lesion, and the X-ray feature, okay, resembles those of a highly aggressive benign giant cell tumor. So just understand like this: if there is a periosteal breakdown, okay, if the tumor is extended, towards the side, if it is a bit of aggressive looking tumor, the soft tissue are also involved, then probably this is a malignant part of that tumor. There is a high risk of metastasis, and treatment require wide or even radical resection. Radical means big area is involved. Sometimes the whole bone may be sacrificed. Now, before I move further, okay, this slide is showing us the different, differential diagnosis of that particular area which is affected. See this? This is a solitary bone cyst which may occur at the same site. This is an aneurysmal bone cyst. Okay, fibrous dysplasia. There is a chondroma. Okay, chondroma is a type of tumor develops from the cartilage. This is chondromyxoid fibroma, another type of tumor. Okay. Now this is chondroblastoma, which is going towards the epiphysis. There is a giant cell tumor. That's what we are talking right now, and there is a brown tumor. Now one small question: this brown tumor is not exactly a tumor. It is associated with one condition. Can you tell me what is that condition? Actually, it is written here. What is this? Anybody? Anyone? Probably you have studied this before somewhere else. What is this? HPT means what? Hyperparathyroidism. Hyperparathyroidism. Now, what happens in hyperparathyroidism? Anybody? What happens? Any student?
Sir,
Yes. What happens to the bone? You can just tell me that.
sir, calcium deposition occur in the bone. Sir, there is destruction of the bone because of high level of parathormone in the.
Okay. Now the answers are coming. See this? In hyperparathyroidism, what happens? Because of excessive activity of parathyroid gland, there will be more, parathyroid hormone. Parathyroid hormone will resorb the bone. It eats the bone away. Okay. So there will be hypercalcemia. There's no doubt about it. But what happens to the bone? That is the important point. Now, that area of the bone is eroded. So there will be some reaction in the bone. Okay. Because of that reaction, a brown tumor is formed. It is not exactly a tumor, it is tumor-like condition. You can understand like this. So this can be asked as a MCQ question in the different exam. It is a feature of hyperparathyroidism. With this discussion, let's enter into the malignant tumor part. Okay, this is a very, very important question in the orthopedic exam, so please pay attention. Now let's start with the meaning of bone cancer. So what is bone cancer? We all know cancer means, okay, this is a malignant counterpart of the tumor, and this is an invasive growth of tumor in the bone. Invasive growth. There are many different characteristic features of a malignant mass. Number one, it is very faster growing mass. There is a high rate of growth. Number two, when we analyze this by histopathology, they are poorly differentiated cells. Number three, it has a property of local invasion. And number four, it has a property of metastasis. So these are the very important feature of malignant tumor. All of these are present in bone cancer also. The bone cancer are of two types, primary and secondary. Primary means it is developed there itself, okay, in the bone. And secondary, it has come to the bone from somewhere else. And that somewhere else means it can be any organ or tissue. Okay, so it can be lung, it can be breast, it can be prostate, it can be kidney, it can be thyroid, it can be GI tract, any. While originates elsewhere in the body and is spread to the bone, they are called secondary bone cancer. When cancer begins in the bone, they are called primary cancer. So you are already familiar to that. Now, let's know the names of those malignant bone tumor according to the age. Now, see this. Neuroblastoma, okay, in less than 1 year. But this neuroblastoma is not the primary bone tumor. This is the secondary one. What is the primary area for the neuroblastoma? Where it develops? Anyone? Where?
Sir, in the
Adrenal?
neuron.
Exact. Adrenal, medulla, or sympathetic neuron. Very good. Adrenal medulla or sympathetic neuron. Because those adrenal medulla are also specialized type of sympathetic neuron only. So you can simply answer like that. Excellent. So this is present in the very young age, neuroblastoma. 1 to 10, Ewing sarcoma of the tubular bone. This Ewing sarcoma is a type of malignant bone tumor. We'll talk about this. From 10 to 30 years, osteosarcoma is quite common, along with Ewing sarcoma of the flatter bone now. 30 to 40, we have different other types of malignancies of the bone, like reticulum cell sarcoma, fibrosarcoma, periosteal osteosarcoma, malignant giant cell tumor, and lymphoma. So many different types. And after the age of 40, now there is a time for metastatic carcinoma, because when the person becomes older, the different malignancies are common, and then they can metastasize to the bone. So that is called metastatic carcinoma. Even multiple myeloma is more common in more than 40 years. This is a malignancy of plasma cell or lymphocyte. So we are going to cover this in this class. And chondrosarcoma is the another one. Now, what are the overall symptoms of the bone cancer or the malignant tumor of the bone? Okay, this is an overall discussion, and we enter into the particular type of bone cancer later on. So there will be pain in the bone. This is a very important symptom of bone cancer. Pain in the bone. Okay, pain in joint, and okay, that joint feel very stiff to move. Pain in the joint, and it feels very stiff to move. This is another important point. Now, this is very true if it is very near to the joint. Otherwise, there may not be any pain in the joint. Okay, and the most common site regarding the osteosarcoma is metaphyseal area. Metaphyseal is very near to the joint, so this is a common feature in that particular cancer. On a reasonable fracture, this is a pathological fracture. Even a slight amount of injury or trauma can break the bone. There is weight loss. Weight loss can be severe in the late you know uh, condition or in a advanced cases. This is a general features of any malignancy. There may be excessive sweating, and there may be inflammatory features at the site. There may be mass formation. It may feel hot. It may appear red, and those features may be present. That's why sometimes it may be also confused with osteomyelitis. Now, what are the causes or etiology of bone cancer? Okay, what are the causes? Now, strictly speaking, okay, we don't know the cause. These are some speculation or hypothesis. Now, sometimes the genetic conditions are responsible for the formation or development of bone cancer. One of the hereditary condition is known as Lee-Fraumeni syndrome. Lee-Fraumeni syndrome. Now, anybody know what is Lee-Fraumeni syndrome? Just one line, maybe. Yes. Anyone?
Sir, hereditary neoplastic condition, multiple neoplasms are formed in the body due to gene mutation of retinoblastoma.
Good. Some of the important points you have highlighted. Okay, Lee-Fraumeni syndrome is the condition where multiple cancers develop in the body. This is an inherited condition. Multiple cancers develop in the body, and it may run in the family. Now, here the P53 gene is mutated. The P53 gene, also known as TP53 gene. What is the function of that gene, P53 gene? Anybody? What is the function?
Tumor suppressor gene.
Tumor
Tumor
suppressor gene.
suppressor gene. Very good, very good, excellent. You just know that much information. This is a tumor suppressor gene. So if it is mutated, it cannot suppress the development of different new cancers. So that is the problem in Lee-Fraumeni syndrome. Now, in this condition, some rare type of cancers develop in the body and different, in the same patient, multiple cancers can also develop. The person may develop leukemia. The person can develop different GI tract malignancy, osteosarcoma, even breast cancer, like that. So this is Lee-Fraumeni syndrome. Radiotherapy can also lead to cancer development in the bone. So we need to take a good history. Probably sometimes in the past, they were treated with the radiation therapy for some other types of cancers. Who knows? So good history should be taken. Sometimes some disease conditions in the bone can lead to development of bone cancer, like Paget's disease of the bone. Okay, some chronic disorders in the bone. You can simply write chronic osteomyelitis here. So Paget's disease of the bone is a condition where, okay, both osteoblastic and osteoclastic activity are going on. Rather than osteoclastic activity, the osteoblastic activity is more important here in case of uh, you know Paget's disease of the bone. But this is an irregular type of bone growth, and those bones are not stronger; they are weaker. They can fracture very easily. Apart from that, there are multiple, okay, anastomosis between arterial and venous system inside these area. And having developed that type of condition, this Paget's disease of the bone can lead to cardiac failure also. Cardiac failure. Now, what is the mechanism there? There may be, uncontrolled amount of blood flow quickly from the arterial circulation towards the venous circulation. Now, that can lead to fluid overload or volume overload condition to the heart. Remember, Paget's disease of the bone is a volume overload condition. Okay, so that can also be noted here. Regarding the metastasis, different site of our body or different organs of our body can develop cancer, and they can spread to the bone. And even smoking is considered one of the etiology of bone cancer. Now, let's talk a little bit about the general things here. See this? There is a normal cell. Okay, these are the different chromosomes. Okay, the normal gene which are present inside the normal cell regulate the cell growth. And this is a normal type of growth. Whereas when this gene are mutated to the cancerous gene, or the cell is developed into the cancerous cell, then it develops very rapidly. The growth and division of that cell is uncontrolled. Okay, this is very basic thing we have already studied in pathology. Now, what are the overall, treatments of the bone cancer? We talked about this in the last class also. So let me go a little bit quickly here. These are the radiation therapy, chemotherapy, and the surgery. All three things can be combined here. The surgery depends on the extent of the lesion. Sometimes we can go for extensive surgery of that local area, and sometimes we can go for even amputation. We sacrifice that limb. It depends what is the you know uh, what is the manifestation when we examine the patient for the first time. Now let's enter into the topic proper. These are the primary, okay, malignancy of the bone. Primary means they develop in the bone itself. So what are those? Very important question in the viva exam. These are osteosarcoma or osteogenic sarcoma. See there? Osteosarcoma or osteogenic sarcoma. These are the synonymous terms. And they develop from bone forming cell, which are known as osteoblast. So you already know, because of this excessive activity of the osteoblast, there is excessive bone formation in that malignant site. And we can utilize this when we take the X-ray. Another is Ewing sarcoma or Ewing's tumor. This develops from mesenchymal stem cells, okay, which is mainly present in the medullary cavity or the bone marrow. To be very precise, these are mainly developed from the endothelial cells, which are present at the medullary cavity or the bone marrow. Another is chondrosarcoma. These are developed from the cartilage forming cell or the chondrocyte. Another is fibrosarcoma. These are developed from the fibrous cell. And myeloma or multiple myeloma, they are developed from B lymphocyte, or we can simply say plasma cell, because B lymphocyte convert into the plasma cell when they are activated. And overall, this is the most common primary bone tumor. So this may be the important MCQ question for you in the exam. Okay, many of the students are confused. If this question is asked, they go for osteosarcoma, but osteosarcoma is not the most common primary bone malignancy. Myeloma is the answer here. What are the important property of this malignant tumor? Though you already know, the two important properties are revised here: invasion or local invasion and distant metastasis. Now let me repeat a bit here. There are four cardinal features of malignant tumor which separate it from the benign tumor. Okay, those cardinal features are: number one, rate of growth. Malignant tumor grow very fast or rapidly. Number two, the histological features. They are poorly differentiated cell, or they are anaplastic cell in case of malignancy, whereas benign tumor cells are well differentiated, means they look almost like the normal cell. Number three is a local invasion, and number four is a distant metastasis. Now, how it happens? Okay, especially in case of bone malignancy, this metastasis occurs because of the blood invasion or invasion of the blood vessels. Lymphatic, you know, uh, metastasis is not that very common. So they invade the blood circulation, enter into the blood vessel, and through the circulatory system, they go to the distant site and they grow there. And again, they may invade the blood and then go to the new location. So this is the way. Okay. So with this, basic uh, concept, let's enter into the topic of osteosarcoma. It's a very important question from the exam point of view. The osteosarcoma is characterized by production of osteoid by malignant cell. Now, this osteoid is a bone. Okay, it is a bone itself. So it is a bone forming type of tumor. This is the second most common primary bone tumor. Please remember, these are the important type of questions, regarding the MCQ exam. And you cannot make mistake in this simple one. Osteosarcoma is the second most common primary bone tumor after multiple myeloma. Regarding the incidence, okay, it is not that uncommon tumor, 2.8 cases per 1 million population. So we can see this frequently. The age group is 10 to 25 years. So quite young individuals are affected by osteosarcoma. Males are more commonly affected than female, except one type of osteosarcoma, which is known as parosteal osteosarcoma, where females are more commonly affected than the male. We really do not know the cause. Why is that? There is a strong genetic predisposition. Chromosome number 13, okay, may be affected in that situation, and metastatic spread usually occurs in the lung. Okay, this is the distant metastasis. For example, the common site is again near to the knee joint, the upper end of the tibia and lower end of the femur. From there, it may invade the blood, and through the blood, it can go to the lungs. Now, see here. Now, it occurs in the long bones, definitely. Where in the long bone? That is the important point. It commonly affects the lower end of the tibia, okay, in the younger individual, and in other people around the knee joint and at the proximal end of the humerus as well. And where in the long bone? It involves the metaphysis area. Let me repeat again. Metaphysis is the area between epiphysis and the diaphysis, and it is the most active part of the bone because epiphyseal plate of cartilage is present right there. So that is the site where osteosarcoma develops. Spread is via the bloodstream to the lung. This is regarding the distant metastasis. And one important point here, in case of older patient, Paget's disease of the bone can give rise to uh, uh, osteosarcoma. So just remember this as one of the you know risk factor for the development of osteosarcoma. And the same person may also develop heart failure and repeated pathological fracture, different deformity of the bone in case of Paget's disease. Skull is one of the common bone which is involved in Paget's disease. Sometimes the face is also affected. And because of the abnormal, proliferation of the bone, the different nerves can be compressed in case of Paget's disease of the bone. So the person will develop neuronal problem as well, apart from the development of malignancy. So we're talking about osteosarcoma. Now this is a schematic diagram which is telling which is the common site for osteosarcoma. Now, see this? This is the end of the bone, lower end of the femur. Uh, this is how the tumor presents. This is expansile type of tumor which destroy the periosteum. It forms the new bone there, and it can also grow into the soft tissue. So this tumor can also occur in some other bone as well. Now, what are the typical clinical presentation? Though we have already listed the important ones before. Okay, please mute yourself. So these are the okay the pain. The pain occurs. Okay, it's a very common clinical feature. The pain occurs at the site of the malignancy. That pain is a constant type of pain, which is a progressive in nature. Means it keep on increasing day by day or week by week. There are different reasons for the pain there. Okay, one of the reason is pressure because of the massive growth of the tumor. Because of the elevation or stripping of the periosteum, there would be pain. Another is due to microinfarction, there would be pain. So multiple reasons are there. And some, in 25% of the cases, night pain is also present. So pain is one of the important, early symptom by which patient comes to the hospital in case of osteosarcoma. Another is swelling. The swelling, okay, is a rapidly growing swelling there, and it is already a palpable swelling in up to one third of the cases when they present to the hospital. Okay, so this is very very important one, and usually the patient presents the swelling near to the knee joint, lower end of the femur and upper end of the tibia. That is the most common site for osteosarcoma. Fever, malaise, or other constitutional symptoms are not typical of osteosarcoma. If they occur predominantly, then probably, okay, some other differential diagnosis has to be thought, maybe osteomyelitis, or sometimes maybe Ewing sarcoma. Now, let's move further. There are different types of osteosarcoma we have, okay, according to the where they usually occur, isn't it? Now, see here. These are parosteal osteosarcoma, periosteal osteosarcoma, intramedullary osteosarcoma, and small cell osteosarcoma. This is predominantly a histological, description. Now, parosteal means outer layer of periosteum. Now, periosteum, if we analyze that properly, it has got one inner germinativum layer and outer, layer. So outer layer, if tumor develops from there or osteosarcoma develops from there, we call it parosteal osteosarcoma. And if the osteosarcoma develops from the inner germinal layer, we call it periosteal osteosarcoma. So that is the meaning. So parosteal is a low grade malignancy than periosteal, which is an intermediate grade. Okay. Parosteal is rare. It occurs more commonly in the elderly, and it is a juxtacortical tumor. Juxtacortical means just next to the cortex. So let's revise what are the layers of the bone once again. Outermost layer is called periosteum, the middle cortex, okay, and the inner is called medullary cavity. So juxtacortical is just next to the cortex. It has better prognosis than classical osteosarcoma, and okay, the most common site is the distal part of the femur. Look at this, radiology or X-ray appearance here. This is the big mass which is present at the distal end of the femur. Now, periosteal arises from the surface of the bone. Okay, of course, because periosteum is present at the surface. So, just by the gross looking, these are very difficult to distinguish from each other. We need to take a biopsy of these things, and biopsy is also a bit of complicated. The most common site is tibial shaft. Regarding the intramedullary osteosarcoma, this is rare and it is a low grade and it is present right inside the medullary cavity. That's why the term intramedullary osteosarcoma, which is rare. This is not a common type at all. And the last one is a small cell osteosarcoma. Now, this is a high grade, means this is a most malignant one, and it resembles Ewing sarcoma or lymphoma, because both of these occur, okay, uh, at the medullary cavity, and they are high grade malignancy, but fortunately it is rare in comparison to the other. Now let's move further. Let's talk about gross pathology of osteosarcoma. Now this is an osteoblastic tumor. We all know that from the classification. We know this is a bone forming tumor, that is osteoblastic tumor. So during the cross section, okay, it looks gray white in nature and it feels quite gritty because it is a hard type of mass. Chondroid type of tumor looks opalescent and bluish gray. The fibroblastic type of tumor looking typical flesh, okay, fish flesh like appearance. And the telangiectatic type of tumor, there is area of tumor necrosis and blood filled spaces. Telangiectasia means multiple dilated blood vessels are present in the tumor, and because they are quite friable, so they can bleed. So there is blood filled spaces inside the tumor. So these are some of the gross morphology. Sometimes all the features are mixed with each other. Now, how to make a diagnosis of osteosarcoma? So diagnosis, okay, depends on clinical features, that is symptom and sign, never forget that part, followed by investigation like radiology or the bone biopsy. So we already talked about those clinical features. So let's talk about the radiology and bone biopsy here. So X-ray can be done, CT scan, bone scan and MRI also can be done in the radiological investigation. Regarding the bone biopsy, a small sample of the tissue is removed from a part of the tumor, okay, and examined under the microscope. Now, what are the findings? Please pay attention. This is the very important part of this class. Now, when we take the X-ray, there is variable combination of bone destruction and bone formation we can see. Okay, it is a combination of destruction as well as formation. This is a malignant tumor. It is rapidly growing. Okay, at the same time, it is an osteoblastic type of tumor. So different features are there, and these features are okay known by the different terms because of the appearance, like sun ray spicules or sunburst appearance and Codman's triangle. These are very familiar terms when we look at the X-ray of osteosarcoma. This Codman's triangle means this is a triangular elevation of periosteum because of the new bone formation there. Okay, we'll see different type of X-ray, and then it is quite clear to you. Now, cortical breach is very common. Breach means breakdown or destruction. This is a malignant tumor, isn't it? It's very obvious. Adjacent soft tissue mass may be seen. Because of the destruction of the periosteum, the tumor may be extended in the soft tissue which is located nearby. Sometimes the joint is also invaded. Okay, joint is also invaded. 25% of them are lytic, okay? 35% of them are sclerotic, and 40% of them are mixed. Now, lytic means destruction of the bone. Sclerotic means formation of the bone. It looks denser in the X-ray. Mixed combination of both. And sometimes telangiectatic type is also there. Okay, and this is purely a lytic type. So these are the different, radiological appearance of the osteosarcoma. Now, all of you, please focus there. This is called periosteal, okay, bone formation. See this periosteal bone formation. Now, this is known as Codman's triangle. This is Codman's triangle. See, look at the elevation of periosteum here because of the deposition of new bone. So, in the schematic diagram, okay, here is a tumor. Okay, there is a tumor. So, this is an osteolytic area because I cannot see anything here. It looks like a big gap, isn't it? There is a destruction of the bone. But in the periosteum, see there is elevation of the periosteum. So it looks like a triangle now. So look at the apex of the triangle and base of the triangle. So this is called Codman triangle. This is highly suggestive of osteosarcoma, and this shows that this osteosarcoma is very aggressive. Okay, this is aggressive type. Now see this. Okay, I can clearly see this a sunburst appearance. Okay, sunburst appearance. See this sun ray spicules or sunburst appearance. Another one, sunburst appearance. Okay, periosteal reaction. Here is a Codman's triangle. This is very clear. It's like a triangle-like appearance, Codman's triangle. So sunburst appearance and Codman's triangle. Very, very typical of osteosarcoma in case of X-ray. Now another one, see there. So this is a very, very good X-ray. Here is a sunburst appearance in this area, but there is a clear-cut Codman's triangle here. Here is another Codman's triangle. You can clearly see the stripping of the periosteum, and here are sunburst appearance. So this is a pathological specimen of the osteosarcoma. Look at the elevation of the periosteum here. Okay, here is the elevation of periosteum. Now these are other X-ray which are telling us the same thing. The metaphyseal site has got increased density. Okay, there is erosion of the cortex also, and the periosteal reactions are quite characteristic. Look at the spicules or sunburst appearance. See here. Okay, this is a Codman's triangle already formed. Here is sunburst appearance, and above is the Codman's triangle. So these are highly suggestive of osteosarcoma. This is known as bone scan. Okay, bone scan. Now this bone scan is showing there is a tumor here. Look at this area. Okay. Now wherever there is metastasis occurring, this bone scan will pick that metastasis as well. Now this is a picture which is showing a big osteosarcoma here. Okay, without any doubt, any student or any doctor can say this look like a malignant growth, and they're right. And looking at the site, this is exactly present near to the knee joint. So this has a high chance of being osteosarcoma. Confirmation is done by X-ray, okay, and the biopsy. Now, what is the treatment? How we are going to treat a case of osteosarcoma? The general discussion was already done, so let us regroup that again. Classically, amputation as soon as diagnosis is made. Okay, so amputation is done as soon as diagnosis is made because this is a highly aggressive type of tumor. But all of the orthopedic surgeons may not agree with this. Sometimes there is something known as limb salvage surgery. They want to protect the limb. If the tumor is excised, widely, along with the combination of radiotherapy and chemotherapy, then you don't need to go for amputation. The same thing is written here. Recently, wide local excision with joint replacement and chemotherapy may work, okay, as well as amputation. If multiple pulmonary metastases are already present at the time of presentation, treatment is by chemotherapy alone. Now, why? Okay, because the metastasis has already occurred. So, what's the point of doing surgery now? The surgery has to be done before metastasis occurred. Okay, it has already occurred. So, chemotherapy is the only treatment at this time. Yes, you can go for some debulking surgery, but that is not usually done in case of limb. Debulking surgery can be done in case of spinal cord compression. That is a vital structure for us, isn't it? If it is compressed, let's decompress it. Then also surgery can be done, even if metastases have already occurred. Solitary pulmonary metastasis may be resected even without chemotherapy. And regarding the prognosis, is see, look at 15 to 20% 5-year survival rate. Okay, so this is one of the cancer which has got poorest prognosis. So without metastasis, the 5-year survival rate is 70%, and if metastasis has occurred, we already talked about, it is around 15 to 25%. So the whole thing here is early diagnosis and treatment. But it is not only in our hand, patients should report to the hospital in time. Sometimes patients themselves are confused. They take it very easily. They think some minor injury has occurred and some small type of fracture has occurred and the fracture will heal itself in time. Actually, they are misguided there. Okay, this was a case of malignancy and they're confused it with fracture or some slight or trivial type of injury, and that's how they do not report to the hospital in time. And already metastases have occurred, and look at the a problem here. The prognosis is very poor. What are the differential diagnosis of osteosarcoma? So any type of condition in the bone can be suspected to have osteosarcoma. Okay, or it can be confused with osteosarcoma, I should say. Like giant cell tumor, this is mainly a benign tumor. Chondrosarcoma, a malignant tumor. Fibrosarcoma, another malignant tumor. Aneurysmal bone cyst, this is a type of bone cyst where the cortex is dilated. Okay, there is a dilation of the bone, there is a distension of the bone. This looks like aneurysm actually. Ewing sarcoma is another important type of malignancy of the bone. Osteoblastoma is a benign tumor. Bony metastasis is a secondary bone cancer. Lymphoma, okay, because those lymphocytes are present in the medullary cavity. Osteomyelitis, okay, this is important differential diagnosis because of the pain and the features of inflammation. And chondroblastoma, this is another benign tumor of the bone. Now, with this, let us enter into the topic of Ewing sarcoma. Another important question which may be asked to the student from this topic. Now, Ewing sarcoma is believed to arise from endothelial cells in the bone marrow. So, this is a mesenchymal type of malignancy which arises from the medullary cavity. It occurs most commonly between the ages of 10 and 20 years, so quite a young age, usually in a tubular bone and especially in the diaphysis area. In the diaphysis area, and these tubular bones are tibia, fibula, or clavicle. So let me repeat again: quite young people in a tubular bone or a long bone, you can say these are the long bones, and especially the diaphyseal area of the long bone. The patient presents with pain. This is a throbbing type of pain, and swelling. Because of this throbbing type of pain and swelling, it is very commonly confused with osteomyelitis. Osteomyelitis also presents in the same way. There is a warm area, there is a tender swelling. Okay, if we test, there is radius R, there is fever. Okay, and the patient looks sick. So these are the features of osteomyelitis. All these features are not that very common in Ewing sarcoma, but the local features may be there. Have a look here. Okay, look at this area. There is a huge swelling there. I cannot say which type of tumor is this. We have to go for a bone biopsy. There's no doubt. But I can give some differential diagnosis, isn't it? We can go for Ewing sarcoma or even osteosarcoma here, and so many other differential diagnoses which we have just seen. So there is another huge mass there. Now, what we see if we take the radio imaging study, X-rays are usually X-rays show an area of bone destruction because this is a bone malignancy. So bone destruction would be there, which unlike that in osteosarcoma is predominantly in the mid diaphysis. Remember this important term. In the diaphyseal area, especially in the middle part of the diaphysis, there is an area of bone destruction and there is a mass. Now, new bone formation occurs in Ewing sarcoma also, but it may extend along the shaft and sometimes it appears as a fusiform layer of the bone around the lesion. It almost looks like an onion peel appearance. So at the center, there is a malignancy, and around that malignant mass, okay, there will be layer by layer bone formation, which looks like an onion peel appearance or onion peel effect. Often, the tumor extends into the surrounding soft tissue with radiating streaks of ossification and reactive periosteal bone at the proximal and distal margin. So because of this, it almost looks like a sunray appearance and Codman triangle. But we need to make sure, okay, these features are very, very common in case of osteosarcoma rather than Ewing sarcoma. So what are the important features? If the teacher asks you, you can quickly list. Osteosarcoma mainly develops from the metaphyseal area towards the end of the bone, whereas if, Ewing sarcoma mainly develops from the diaphyseal area. In Ewing sarcoma, the onion peel appearance is more common than this X-ray, sunray appearance or sunray spicules and Codman's triangle appearance, though it can be seen even in Ewing sarcoma. Now, see here, there is a Ewing's tumor, examples of Ewing's tumor in the humerus. This is humerus, isn't it? The mid shaft of the tibia, okay, and the lower end of the fibula. So all these things are shown here. Okay, see this. Now, there is osteolytic lesion, okay, osteolytic lesion here, but at the border, I can see some dense areas. So there are osteoblastic areas also seen. So in the bone, just compare with the cortex. If some area looks similar to the cortex, that is osteoblastic area. If the density looks thinner than the cortex, this is osteolytic area. As easy as that. What is the treatment of Ewing sarcoma? The prognosis is poor in case of Ewing sarcoma, and surgery alone, okay, does little to improve it. So only surgery is not very helpful. We have to combine all three methods together, and those three methods are chemotherapy, radiotherapy, and surgery. Okay, a lot of information is shown there. You just remember like this. Okay, for the undergraduate student, that much information is enough. Chemotherapy is much more effective, offering a 5-year survival rate of about 50%. And if possible, all three methods are always used. Now, sometimes post-operative radiotherapy may also be added there. Okay, after the surgery, radiotherapy is given. So that's if some leftover masses or tissues or malignant tumors are there, they would be destroyed. Now, what is the overall prognosis? We already called it poor But what about according to the percentage? The prognosis for this tumor has improved dramatically since the introduction of multi-agent chemotherapy. From an erstwhile 10% survival rate to the current 70% for the patient with non-metastatic Ewing sarcoma. Now see there, before, okay, erstwhile means prior, okay, or before, in the past, where before these chemotherapy were introduced, probably the prognosis rate was just 10%. Okay, a survival rate, the 5-year survival rate was 10%. Now, because of the use of this chemotherapy, it has climbed up to 70%. This is a very, encouraging fact for us. Now, with this, let's enter into the another type of bone malignancy, which is known as multiple myeloma. So, in fact, this is the most common type of primary bone malignancy. Now, look at the meaning here. Every student know this already. This is a malignant B-cell lymphoproliferative disorder of the bone marrow with plasma cells predominating. So you can simply say this is a plasma cell malignancy. Plasma cell malignancy which arises from the bone marrow. That's why it is also known as a type of bone malignancy. In fact, it is the number one primary bone malignancy. The effect on the bone are due to marrow cell proliferation and increased osteoclastic activity. This is important point here. Because of this increased osteoclastic activity, there is generalized osteoporosis. And even more important than that, there are appearance of discrete lytic lesion throughout the skeleton. These are called punched out lesion, okay, in the skull and in other bones as well. And these are the hallmarks of multiple myeloma regarding the diagnosis. We'll talk about that. Sometimes a particularly large colony of plasma cells may form what appears to be a single or solitary tumor, and that is known as plasmacytoma. Now, plasmacytoma is a solitary tumor, but if we take a biopsy from that and analyze it, it contains, plasma cell itself. So it is a variety of multiple myeloma. You can understand like this, but it is a single area. Multiple myeloma can occur in different bones. Now, what are the other associated features of the marrow cell disorder? They are plasma protein abnormality. These are the malignant cells, okay, or malignant plasma cell, you can say. And the function of plasma cell is the synthesis of antibody. So there is abnormal antibody formation in a large amount. We call them M band, okay, or M protein. They are the light chains. Because of this, there is increased blood viscosity and there is a high chance of anemia as well, because this is a problem of the bone marrow. Because of the increased osteoclastic activity, remember that there is a increased bony resorption. This bony resorption leads to hypercalcemia. Okay, many of the students have already answered this to me. Now, because of this hypercalcemia, okay, there is renal dysfunction. There is renal dysfunction. A lot of calcium is excreted in the kidney. Some of that calcium may lead to renal stone as well. Okay, those renal stone may block the kidney and can damage it. That is one point. Another, because of this excessive formation of the abnormal protein, these proteins are also, excreted in the urine, and these are known as Benz Jones protein. At the same time, there may be spinal cord or spinal root compression caused by vertebral collapse. Because those vertebrae are damaged, okay, they become weak. At the same time, there is a compression fracture of the vertebra, and when that occurs, the overall spinal cord or even the spinal root can be compressed. So the person may present with paraparesis or paraplegia, bowel and bladder dysfunction, as well as, okay, as well as root compression pain. This is known as radicular pain in some particular dermatome. Let's move on. Now, what is the age group? This tumor usually occurs, okay, uh, above the age of 40. So patients are typically aged 45 to 65 years, and they present with generalized weakness, backache because vertebrae are very commonly affected, pain in that affected bone, or even the pathological fracture. So, similar to other types of bone malignancy. Hypercalcemia is quite common. These are the common features of hypercalcemia. See there? Excessive thirst, polyuria. Okay, this polyuria leads to excessive thirst. This is called polydipsia, and even the abdominal pain. This abdominal pain may be there because of pancreatitis. Hypercalcemia can lead to pancreatitis. Regarding the other clinical sign, apart from pathological fracture, there are not many. Okay, there are not many. But pathological fracture itself can give rise to a lot of clinical feature. If it occurs in the vertebra, there may be paraparesis or paraplegia in the patient. There may be bowel and bladder dysfunction. You can, describe like that. In the affected bone, there is localized tenderness, okay, and there is a restricted hip movement if this malignancy occurs very near to the hip joint, especially if there is a solitary tumor which is known as plasmacytoma occurring in the proximal part of the femur, very near to the hip joint, then there is a restricted movement of the hip. In late cases, there may be signs of spinal cord or spinal root compression, chronic nephritis, as well as recurrent infection. Because this is a relative immunodeficiency situation. Whatever antibodies are synthesized, they are abnormal type of antibody. So there is a chance of recurrent infection as well in the patient. Let's move on. Now, how to diagnose it? Okay, there are certain investigation we can go for. One of that is X-ray, and X-ray is very suggestive here. X-ray often show, okay, generalized osteoporosis, but sometimes it can also show vertebral compression fracture. Okay, vertebral compression fracture. The classical lesions are multiple punched out defect with soft margin. That means those osteolytic area, okay, if we look at the margin of those osteolytic area, there is no extra bone formation. That is called soft margin. There is a lack of new bone synthesis. This is a very important point to remember. There is a lack of new bone synthesis. And what types of bone are usually affected? Skull, pelvis, and the proximal femur. Sometimes the crushed vertebra or already, the collapsed vertebra can be seen. And sometimes, if it is a case of plasmacytoma, there is a solitary lytic tumor is seen, especially in the upper part of the femur. Now, okay, after going through those discussion, let's see these, X-rays now. Look at this punched out lesions. They're highly typical. See this? So many. Okay, and I cannot see any extra new bone formation at the margin. It's also here. Look at this skull. See this punched out lesions here. Okay, these are the ribs. So flat bones and the long bones, every type of bones can be affected. This is the vertebra. Look at the generalized osteoporosis of the vertebra. And see here, okay, this is a solitary lesion. So this is a plasmacytoma, solitary type of lesion. So this is how it manifests in the X-ray. Now, what are the other investigation apart from X-ray? We can go for CBC, and CBC shows mild anemia or severe anemia. It depends on the course of the disease. And almost constant feature is very high ESR. So remember, this may be an important question in the medicine or in orthopedics. There are certain situations or conditions in our body which has high ESR, and this multiple myeloma is one of them. What are the other conditions where there is very high ESR? Yes, anybody? Who can answer? Anyone?
Infections, inflammation,
Mm-hmm. Yes, good. Okay, so let me.
autoimmune
Tuberculosis.
disease.
Good. Autoimmune disease, very good. Tuberculosis, somebody is saying tuberculosis. Nice. Now, listen, I like to elaborate a little bit here. Any type of infection or inflammation can give rise to high ESR. Very good. There's no doubt about it. Okay. But how high? That's the question. There is very high ESR, like if ESR is more than 75 or even 100, then it is very high ESR. Normally, it is about 5 to 15 millimeter at the end of 1 hour. So, tuberculosis is one of the condition. Connective tissue disorders are some other. Okay, Kawasaki disease in case of children is another one, and this multiple myeloma is the fourth one. You have to remember these because they are quite catchy questions from the exam point of view. If we do a blood chemistry, it may show a raised creatinine level and hypercalcemia. There's no doubt about it. Raised creatinine level because of renal dysfunction, and hypercalcemia is because of bone resorption. If you do the ultrasound of the kidney or even plain X-ray of the kidney, sometimes the renal stones can also be seen. Over half of the patient have Benz Jones protein in their urine. This is a very typical features of multiple myeloma. Never forget this important MCQ question in the exam. And if you do serum protein electrophoresis, it will show the abnormal M band there. Okay, it is called M band, which is highly typical. So Benson's protein in the urine, M band in the protein electrophoresis of the serum. Okay, and those punched out lesions in the different bone. These are highly typical of multiple myeloma. If you want to prove whether these multiple myeloma cells are present in the bone marrow or not, you can go for a marrow puncture or bone marrow biopsy or aspiration, you can say. Okay, you don't need to go to the sternum, you can go to the other bone as well. It may show plasmacytosis with a typical myeloma cell. Okay. Now we are towards the end of this big topic. Okay, now what are the treatment? The treatment depends. Uh, we can divide this treatment into two parts: symptomatic and supportive treatment, and the definitive treatment. The immediate need is for pain control if pain is there, and sometimes pathological fractures are also there, so pain control is necessary. Another one, the general supportive measures include correction of the fluid balance in case of hypercalcemia, because patient is having polyuria and polydipsia. Okay, especially polyuria. Patient may be dehydrated, so fluid balance has to be done. Now, if limb are already fractured, remember this is a pathological fracture, so open reduction and internal fixation is usually done with some type of bone graft also needed. If there is a big defect or gap, sometimes it has to be filled with cement also. Perioperative antibiotic prophylaxis is necessary because this is a relatively immunocompromised condition. And then if spinal fractures are there, okay, we should stabilize the spine. Otherwise, there is a high chance of cord compression. What are the specific therapy? It is treated by radiotherapy or chemotherapy. Okay, one of the important drug is called melphalan. It is an alkylating cytotoxic agent, and sometimes corticosteroids are also used for the treatment. Now, the prognosis is usually poor, with the median survival rate survival time is between. Let's move on. Let's talk about the metastatic bone disease now. So this is the last part of the discussion in this big topic known as bone tumor. Now, let me start with one fact. If the question is asked in the MCQ exam, what is the most common type of bone tumor? Not primary, not secondary, overall, your answer is metastatic bone disease. though it is a secondary type of bone malignancy, but it is much more common than the primary. And if the question comes, what is the most common primary bone malignancy? The answer is multiple myeloma. Okay, you just have studied that. Now, what type of metastatic bone disease can occur? See here. These are different type like osteolytic. Osteolytic. What do you mean by osteolytic? There is a destruction of the bone. Osteolytic. There is a cortical destruction with little or no periosteal reaction, and they usually metastasize from the lungs, from the kidney, from the adrenal gland, from thyroid, and from the uterus or endometrium. These are the osteolytic type of metastatic bone cancer. Some other are called osteoblastic deposit. Okay, like see there, they mainly go from the prostate, from the urinary bladder, from the testes, from the breast in case of female, and from the colon, okay, especially the colon cancer. They are the osteoblastic. Also the carcinoid lung tumor and lymphoma as well. Carcinoid means serotonin producing tumor. Now some other tumors are the mixed, means they have got both component osteolytic as well as osteoblastic, and this may be the breast cancer. See here, breast cancer, lung cancer, ovarian cancer, and cervical cancer in case of female again. Okay, so osteolytic, osteoblastic, and the mixed growth. Lymphoma deposit may resemble prostatic deposit, that is sclerotic secondary. Always remember, prostate is one of the very common malignancy which causes osteoblastic, deposit in the bone. And lymphoma are usually confused with prostatic deposit. Whereas renal cell carcinoma and thyroid cancer can lead to osteolytic type of bone growth, that is expansile, and it also involves the soft tissue. Now, let me ask you one question. Which type of thyroid cancer usually metastasizes to the bone? Which type? Which one? Which one is that? Anybody? Is it papillary? Is it follicular?
Follicular.
Follicular cancer
Exactly.
can spread to the bones and lung.
Exactly. It is follicular type. Okay. Remember that. This is a follicular type. Very good. So this type of questions can be easily asked. Not the whole topic. These days a lot of questions are the MCQ based question or the short question. This type of questions can be asked to you. Now, one important information here regarding the metastatic bone tumor is when you take the X-ray of the vertebra, if it is metastasized to the vertebra, now there is a winking owl sign which is seen. Winking owl sign. So this usually occurs if the one pedicle is damaged and other pedicle looks fine. And for that to happen, at least 50% of the bone has to be destroyed. Then only the osteolytic lesion can be seen. Now let's see what is that winking owl sign looks like. See here. Now see this. So this is the winking owl. Okay, the owl is about to close one eye and another eye is wide open. So we are comparing this type of appearance to this X-ray. Now see here, this pedicle is damaged. I cannot see this pedicle. See this? This is called pedicle. Okay, this is called pedicle. So this pedicle is normal on this side. Here it is damaged. So they are simply comparing this overall appearance with the winking owl. Here is the beak of the owl. Okay, so this is called winking owl sign. And if this type of question is asked, you can confidently answer. They are trying to talk about metastatic bone cancer in the vertebra. Look at the another X-ray. Okay, again the same type of things are trying to show here. This is the pedicle. So there's a destruction of the pedicle on one side. Pedicle is normal on the other side, and this is spinous processes look like a beak. So this is a winking owl appearance. Now, what are the treatment options in case of metastatic bone tumor? Surgery doesn't play a role here. Okay, radiotherapy also has a very minimal role. So this is treated mainly by chemotherapy because extensive metastases have already occurred. So the common chemotherapeutic agent which are used in the treatment of this bone cancer are methotrexate, doxorubicin, also known as adriamycin, cisplatinum, ifosfamide, etoposide, cyclophosphamide, and vincristine. These are the different chemotherapeutic agent or anti-cancer drug. These are not the common questions for you in the exam. You can simply say chemotherapeutic agents are used for the treatment of metastatic bone tumor. That's it. Now, if these chemotherapeutic agents are used, then they have multiple side effects because they are very powerful drug. Okay, they have multiple effect in different types of tissues or cells. They can suppress the bone marrow. So there is bone marrow aplasia. What happens if bone marrow is aplastic? What happens?
Aplastic anemia, pancytopenia.
Very good. You can say pancytopenia. Excellent. So there will be anemia, there will be leukopenia, and there is thrombocytopenia. Nausea and vomiting, very non-specific feature, loss of appetite, pain in the mouth because of the oral ulcer formation. This is again the manifestation of neutropenia. And another reason you can give, these chemotherapeutic agent, they
Fungal infection, candidiasis.
exactly, very good. And another reason, they affect the rapidly proliferating cell, and the cells of those epithelial tissue, or the epithelium wherever it is present, they are also damaged by this chemotherapeutic agent. So there may be oral ulcer formation, and that oral ulcer is very difficult to treat in this case. And whatever microorganisms are present inside the oral cavity, they can migrate to the blood through this ulcer. So this is a serious feature here. Hair loss, very important one. uh, Kidney failure, constipation, diarrhea. Again, constipation and diarrhea, non-specific feature. Different type of skin changes or pigmentation and pain in different parts of the body can be other side effects of chemotherapy. Now, at last, methotrexate is one of the very important drug or chemotherapeutic agent. So sometimes the question may come from the toxic effects of the methotrexate. So that's why this is listed here. It can cause leukopenia, okay, or you can say it can cause pancytopenia. There may be some non-specific features like diarrhea, nausea and vomiting, or stomatitis. This is inflammation of the oral cavity. Stomatitis also leads to oral ulcer. Alopecia is a loss of hair. It can cause hepatic toxicity, and it can also lead to renal toxicity. So these are the different problems of methotrexate.